Thank you for joining us for Conversations and Cases in Oncology, updates in the treatment of early non-small cell lung cancer, expert opinion. In this segment, we'll be discussing adjuvant therapy in early-stage non-small cell lung cancer. My name is Dr. Stephen Liu, Associate Professor of Medicine and Director of Thoracic Oncology at Georgetown University. I'm joined by my expert colleagues, Dr. Jamie Chaft from Memorial Sloan Kettering, Dr. Julie Brahmer from Johns Hopkins University. We'll cover a few topics today, but where our focus really is on early-stage lung cancer, where the goal of therapy is cure, and the best path to that goal is surgery. But even for an early-stage lung cancer, and even with a perfect surgery, we know the risk of relapse is quite high. And compared to other solid tumors, like colon cancer, prostate cancer, even early-stage lung cancer has relatively modest 5-year survival rates. Our desire here is to really target and eliminate microscopic disease after surgery that is responsible for that relapse. And historically, we've relied on chemotherapy. But the benefit of chemotherapy overall is fairly modest. While there are notable toxicities, there is a measurable survival benefit, but the absolute benefit of about 5% at 5 years certainly leaves room for improvement. Chemotherapy is still our standard. There's some debate as to the role of radiation, which wouldn't necessarily be considered standard now. But if we look to advanced lung cancer, chemotherapy is not really our standard. We use targeted therapy for driver-positive lung cancer. We use immunotherapy for driver-negative. And so the question is, can we translate those advances to earlier stage lung cancer to further improve outcomes? If we start with targeted therapy, really the scene is set with ADAURA. The ADAURA trial is an adjuvant study looking at the EGFR kinase inhibitor osimertinib versus placebo for completely resected stage 1B, 2, or 3A non-small cell lung cancer that harbors a sensitizing EGFR mutation. As we can see from these data, the use of adjuvant osimertinib significantly improved disease-free survival. In stage 2-3, the hazard ratio here is 0.17, and these Kaplan-Meier curves split immediately and widen over time. I know that when I saw these data presented by Dr. Roy Herbst at ASCO 2020, I found them to be very striking. I've just never really seen Kaplan-Meier curves like this. Jamie, this is something that I know you've been doing at Memorial for some time. Were you surprised by these results?
I'd say I was happily surprised with the degree of effect seen in the study. It was truly remarkable. We couldn't have asked for more, honestly. So it's exciting data in clinical practice, I think, equally as fun to prescribe because the drug is well tolerated. But of course, we still await more mature data to convince us that this is the right thing to continue to do. And I think it will be. But I was surprised, happily so, and eager to continue prescribing it in the clinic.
Yeah, I agree. In stage 2-3, which was sort of the big result there, we saw that hazard ratio 0.17 when we fold in stage 1B, hazard ratio 0.21. If we look specifically at stages in stage 3, our DFS hazard ratio of 0.12, stage 2, 0.17. But for stage 1B, which was sort of less benefit, still a disease-free survival hazard ratio of 0.39. Julie, is this something that you offer to patients with stage 1B resected lung cancer?
Yes, certainly. We know that these patients can recur, particularly our EGFR mutated patients with the early stage disease do have a propensity to recur. And I think I also am comforted by using this in the adjuvant setting to prevent CNS metastases, since this can occur, particularly for patients with EGFR mutant disease. You know, the data did show a decrement of CNS metastases occurrence. So, you know, I offer it. We'll see whether or not some of my patients take it. You know, as Jamie said, you know, this is relatively easy to tolerate, but in the adjuvant setting, we definitely have a different patient population, and those toxicities, even if they are less compared to chemotherapy, they can be significant for our patients.
I absolutely agree. Also, we have to think of the cost of a drug that we're taking for 3 years, which is not negligible. But as you mentioned, these Kaplan-Meier curves in terms of CNS disease-free survival, they split pretty quickly. I also think that when I look at these Kaplan-Meier curves, I'm struck by just how poorly the standard arm does. You know, if we think of a stage 1, stage 2 lung cancer with adjuvant chemotherapy when appropriate, our goal there is cure, but we're not doing a very good job with standard therapy. So I think this is a welcome improvement. Certainly a lot of questions remain. We see a major disease-free survival endpoint. Will that translate to an overall survival benefit? What happens after we stop giving the osimertinib at 3 years? Are there biomarkers that can perhaps guide the use of therapy? And should we extrapolate this to other targets? I think a lot of important questions that remain to be answered. Now, this is specifically for patients with a sensitizing EGFR mutation in their resected tumor. That is the minority of lung cancer today, and most patients will not have one. We turn to our other major advance in the past few years, led largely by the two of you, and that's immunotherapy. We saw Dr. Heather Wakely present the Empower 010 data at ASCO 2021. This looked at adjuvant atezolizumab, a PD-L1 inhibitor after adjuvant chemotherapy for completely resected 1B, 2, and 3A non-small cell lung cancer. It allowed patients with any PD-L1 expression, but really sort of categorize responses based on PD-L1 expression. Patients were then randomized to atezolizumab every 3 weeks for 1 year, or best supportive care, so not a blinded study. As we saw here in these event-free, disease-free survival curves, they split again pretty quickly. Not the same degree to which we saw with ADAURA, but still a significant improvement in disease-free survival, while the hazard ratio of 0.66, I think, is substantial in stage 2-3 PD-L1 positive. Based on the hierarchical design, we then look at stage 2-3 all PD-L1 expression, and it retains its statistical significance with a hazard ratio of 0.79. Then that triggers the intent to treat population that did not quite meet statistical significance with a hazard ratio of 0.81, but not statistical based on their thresholds. And so we don't formally look at survival just yet. But I think we'll agree that our interest at this point in 2022 was on the specific PD-L1 strata. And if we look at PD-L1 high, we see, as with most studies, PD-L1 high group is carrying most of the benefit with disease-free hazard ratio of 0.43. We just saw a DFS hazard ratio of below 0.2. Now we're seeing a DFS hazard ratio of 0.43 for PD-L1 high. In that group alone, is that a substantial benefit for disease-free survival? Julie, is that number good enough?
I think in my mind, yes, I'm sold. But I think that, we'd love to see overall survival coming up as well, but that's going to take some time. But, certainly in my clinic, it is good enough.
And Jamie, in that PD-L1 low group, so PD-L1 1 to 49%, while not super well powered, our hazard ratio there 0.87. My question to you, is that good enough?
Give me the hard question. It's worth a discussion. Mm-hmm. The FDA label in the US has approved this drug in the adjuvant setting for greater than 1, and I'm sure you'll get to it next. The other resulted study is a bit conflicting when we look at the data. It's really unsure now what to make of it. In the 1 to 49 group, it's absolutely discussed. We have to remember that PD-L1 is an imperfect biomarker, and there are certainly others that we don't yet fully grasp, whether that's tumor mutation burden or other immune signatures. So I think we take greater consideration about the risk in that population, but in my clinic, the drug is offered.
Yeah. I agree. And Dr. Enriqueta Philippe at ESMO 2021 presented sort of a unique way to look at that data in the PD-L1 low group, taking out EGFR mutant and ALK fusion patients. And in that subset of EGFR ALK wild type PD-L1 low, the hazard ratio of 0.82, a little closer, I think, to sort of our bar. And I do think it is definitely worth a discussion. Do we agree, though, that in the PD-L1 negative group, where our hazard ratio is right around 1, this does not seem to be providing much benefit? Would we agree with that?
I agree.
Yeah. Because as you mentioned, Jamie, there are toxicities. These are well-tolerated drugs, but they're not completely benign. And we only want to offer them if they offer some benefit. In that PD-L1 negative group, I just think this probably isn't the right strategy. When we look at the toxicities overall, here we see immune-related adverse events, obviously more common with atezolizumab, but primarily low grade. Very few requiring the use of systemic steroids, but still not a completely benign therapy. So we only want to expose patients to risk when there is some modicum of benefit. And I think that definitely in PD-L1 high, it sounds like we're all in agreement there. The PD-L1 low, I think that we would certainly discuss it and at least offer it. As you mentioned, Jamie, atezolizumab was approved in the adjuvant setting by the FDA October 15th, 2021, based on the PD-L1 of 1% or greater threshold. And currently the recommendation for EMA is actually that higher bar of 50% and specifically an EGFR ALK wild type. Now our label doesn't sort of specify EGFR ALK wild type, but is that something you would do in practice? Is this off the table for someone with an ALK positive lung cancer? Jamie, is that just a totally different cancer?
It is. For me, it's off the table, irrespective of PD-L1 expression. I wish we had greater access to trials of ALK inhibitors in the adjuvant setting, modern ALK inhibitors. The EGFR space, osimertinib, just looks so compellingly positive, at least in terms of DFS. So in my clinic, if the data is known, and it should be, there's a large tumor in the lab, the atezolizumab's off the table.
Can I give you two harder ones? I'll give the harder questions to hear Julie. Let me give you these two harder ones. What if it were RET positive? What if it were BRAF V600E positive? Are you still thinking adjuvant atezolizumab for those?
So I think a lot also depends on whether or not this patient was a smoker. RET positivity usually is associated with never smokers, so I probably would not be giving a TKI. I would just give chemotherapy and try to find a trial. For a BRAF V600E, if I have many patients that do well with immunotherapy, but typically they are also have a history of smoking. So I would actually advocate for them to receive immunotherapy based on their PD-L1 status. So not all driver mutations are the same. Obviously, all of these patients, we should try to get on a trial for the TKIs, but if they are not available, considering their smoking status may be helpful in these cases, or particularly for those mutations where we have good data for IO, say KRAS G12C, the BRAF V600E, maybe even the MET exon skipping mutation. Again, if these folks are smokers, I would probably lean towards IO depending on their PD-L1 status.
So I completely agree. I see Jamie nodding too. So Jamie, does that mean that we should be sending full molecular profiling on resected lung cancer now?
I think so. I mean, for many reasons, beyond the personalization of adjuvant therapy, we are still faced with the reality that many of these patients will have recurrent disease in the future, and having that information readily available is always an advantage. But I think every ounce of genomic information really guides us.
Now, you mentioned another adjuvant trial, and that was the PEARLS study, which Dr. Luis Pazarez presented in the virtual plenary at ESMO. This looked at adjuvant pembrolizumab, a little bit of a different design, though. Here, dual primary endpoints in the overall group and the PD-L1 high group. And when we look at these Kaplan-Meier curves, we see overall the study was positive with a hazard ratio of 0.76 for disease-free survival. When we look at that PD-L1 high group using that 50% threshold, hazard ratio actually a bit worse. Survival curves that sort of kiss and maybe even cross a little bit, and the hazard ratio of 0.82. And then when we look at these forest plots, we see that it doesn't really follow the same pattern where we're used to seeing the most benefit in PD-L1 high, a little less in PD-L1 low, and then maybe none in PD-L1 negative. And we just don't see that. And we have pretty good numbers, but the highest benefits seem to be in PD-L1 low, and then PD-L1 negative and PD-L1 high were sort of tied with each other. When we look at the EGFR group, while they are smaller numbers, that EGFR group did seem to benefit. Jamie, am I wrong in saying this kind of goes against what we know about immunotherapy?
It goes against all common sense, and there is a lot of censoring. So I look forward to more mature data, but I can't make sense of it.
Yeah. And Julie, I mean, you don't think that pembrolizumab and atezolizumab are inherently so different that the biology would be totally distinct from these two studies, right?
No, I don't think so. And just like, I just want to put my hands on my head and just, I'm so confused with these analyses of this data. It just doesn't make biologic sense. Unless some of these PD-L1 high patients do actually have driver mutations, and maybe that's what's changing the data there. But we just need more data, and just like Jamie said, more time.
So let me close here with just a quick case. This is actually a case of mine, so I'm going to get a second and third opinion here for free. This is a 60-year-old female smoker, had a screening CT from her primary care doctor that revealed a 3-centimeter right upper lobe lung mass, and so was sent for bronchoscopy, EBUS, nodes negative, everything was done right, went to resection. Despite having the EBUS, actually the final path did show up microscopic involvement of an ipsilateral mediastinal node. So we have a 3.1 centimeter primary, a T2A, with an R4 node, so T2A, N2, 3A. Next-gen sequencing showed a KRAS G12V, and PDL1 here was 20%. So PDL1 low, KRAS mutant lung cancer. First question, postoperative radiation therapy, any role now for mediastinal nodal positive lung cancer? Jamie, a little smile there. What do you think?
I mean, unfortunately, the Pearl study was imperfectly designed, and I'm sorry, not Pearl, Lung Arch study was imperfectly designed, and the endpoint was powered to be almost unrealistically positive based on all retrospective data. However, we have now no prospective data for radiotherapy for this incidental N2, which is exactly what you described. So in the absence of extranodal extension or bulky N2 disease, I think in this particular patient, no role for radiotherapy.
Julie, adjuvant chemotherapy, safe assumption here for N2?
Yes, absolutely. This is the patient population. If you're going to benefit, you should benefit. So I definitely talk with the patient here.
And how, in your own practice, if you wouldn't mind sharing, how strict are you with, I mean, the strongest data are cisvinorelbine, right? I don't know a lot of people are using that drug anymore. How strict are you with that? Are we okay to use other doublets?
I used other doublets, based on the ECOG 1505. It doesn't seem like there's that much difference. If you want to be a purist, stick with the vinorelbine cisplatin, but I have a hard time getting patients through the whole regimen. So, if adenocarcinoma, I tend to go with pemetrexed and cisplatin. If squamous cell, then certainly either docetaxel cisplatin or gemcitabine cisplatin. So it really also depends on the patient and what sort of toxicities I have to avoid. So.
And to close out here, PDL1 20%, Jamie, is this a case where you will offer, recommend, discuss atezolizumab? What's your approach there?
I will certainly offer it, and if the patient is a heavy smoker, probably recommend. The risk of recurrence is just so high, so anything we can do for stage 3 to prevent recurrence, worth trying.
Yeah, I agree. Well, this has been great. It's like talking to up-to-date in person or two textbooks right side by side. So to the viewers there, thank you for joining us for this segment on adjuvant therapy in early stage non-small cell lung cancer. Be sure to click on this activity landing page to claim your AMA, ANCC, or ACPE credit, and to access other topics such as neoadjuvant therapy in early stage non-small cell lung cancer and therapy in special patient populations.